experiencing. Thanks, Lauren. Thank you, and thank you to the team for joining us today. I think we want to start with generally asking all of you, how have your teams been going? And can you share with us what it's been like working over the past few weeks with COVID patients? I guess we'll start with you, Megan.
Sure, thank you. I think for many of us, we haven't quite processed that Christmas and New Year's have happened. It's been an incredibly busy couple of weeks, and I'm inordinately proud of everybody who's been working in the COVID clinical pathways. And as both Leslie and Rachel have mentioned, this wouldn't be possible without the support from our entire network to achieve what we have. So in a matter of weeks, we've got 13 wards upstairs, which contain 200 patients who have COVID. This isn't something we ever could have imagined being able to do in the space of a few weeks. And I really want to just emphasise the flexibility, the agility and the willingness to serve and stepping up that we've seen from all of the teams on the ward. Particularly the leadership of the 102 inpatient service, which is Lauren Filkey and Alice O'Connell doing an amazing job, and the flexibility of the medical workforce there. I think we've seen our nursing colleagues do absolutely amazing things. Particularly I was on 7GB and I was speaking to Kathy, who's normally the num of the 23-hour ward, and she said, I feel like I'm a fish out of water here. I've got a ward full of patients with COVID, but I'm going to absolutely do my best. And it's just been brilliant to see everybody leaning in to support colleagues and making sure that we've all got what we need to be able to provide the care we have for our patients, and obviously partnering with intensive care and obviously in the emergency department as well. But the support we've had from all of the different programs has been absolutely brilliant. And I'd be remiss if I didn't specifically mention the amazing guys in mental health, who I think have been early adopters of the incidental COVID pathway, and that's work that they've actually been doing for over a year. But they've had, up to 6 patients who have COVID, who are not unwell with the COVID, but require a mental health admission, and they've been absolutely brilliant in the way that they've cared for those patients.
Anyone else would like to add anything?
Yeah, I'd like to echo what Megan just said. I think the teams have come together very nicely across the network and within the state. And certainly within Carlton, the clinical operations cell, also known as the clinical advisory group, has been very productive in terms of trying to distill the thought from all the other departments in terms of coming together with some tangible items and making sure that we do the right thing for our patients. So that has been really inspirational, I have to say. And more importantly, I think it's been a multidisciplinary activity. We've taken everyone along with us, nurses, allied health, administrative staff, and everyone has stepped up to the plate.
So what kind of symptoms are people presenting with? Yes, ask you on that?
Yeah, sure. So from an intensive care perspective, we often see people at their most vulnerable time when they come to intensive care and essentially in a deteriorating phase of their COVID pathway. So we'll either accept them from the lovely folks in ED straight up, or we'll take them from the ward in a medical emergency and or a review system. We're finding that when the patients come to intensive care, they are quite a sick state, requiring a lot of high oxygen flow requirements. And it's quite interesting because we're seeing that these patients, whilst they might have a very high oxygen requirement, they can carry a conversation with you, which is quite unusual for what we would typically see in a type 1 respiratory failure, which is an oxygen depletion. So these patients could be saturating at very low levels and having a conversation. We would normally expect them to have a very high work of breathing and really look as though they're tiring from a respiratory phase. So that's been quite not challenging, but we have to monitor them very closely, because when they do tire, it's very quickly, and we have to escalate our therapy very quickly. And they've been very unwell if they do eventuate to be intubated and ventilated. But that's our core business. We get in there, we've all stepped up, and we've really risen to the challenge with a multi-D focus. I think that's something that we definitely, from an intensive care purpose, have really banded together from all allied health, nursing and medical. And we've taken care of our patients, and I'm very, very, very proud of what we've been able to achieve so far, and I think we'll continue to achieve.
And so from an ED perspective, what are the kind of things you're seeing coming through the door with COVID patients?
I think, yeah, so definitely the classic symptoms that we were seeing, you know, shortness of breath, increased work of breathing, fever. But we've certainly noticed an increase in GI symptoms. So diarrhea, especially with Omicron, seems to be one of the symptoms, and pleuritic chest pain has been a lot of that. And now with the RAT tests, we're seeing a lot of incidental COVID findings as well. So they're presented for a variety of reasons, and they happen to have COVID as well.
And have you noticed, I guess, both in the ED and in ICU, is there been a big difference between what we're seeing now to what we saw in 2020?
Yeah, so it's a good question. So when it happened in 2020, we were certainly in no man's land. We had this fear factor of the unknown. So when the Alpha variant came about, and since then, I think we have learned a lot, both from our experience within Australia, but also learning from experience overseas. Unfortunately, we have had this leading time. So when the Alpha variant occurred in March 2020, we had the time after it happened in Italy before it came into Australian shores for us to learn from that experience. So this time around, we've had the time to learn from experience interstate, particularly New South Wales and Victoria. So that has given us the time to actually upskill and also make sure that our knowledge base is contemporaneous, it is evidence-based, and more importantly, we are completely prepared to face any eventuality. And also now that we have the experience of having these patients previously, we had about 18 patients come through ICU in the first wave. In the second wave, we had about 4 patients. And now this time around, since the borders opened on the 23rd of November, we have had about 49 patients in ICU. So that's, if you put all two together, it's a significant body of work, which obviously has given us experience, the technical know-how, and the skills that go along with it. In addition to that, in terms of the disease pattern as such, I think when we had patients initially during the first wave, it was a multi-system issue. We found that they had a significantly high incidence of renal failure, the requirement for dialysis, they had clotting issues, and also we found that those patients needed not just one specialty involvement, but a multi-specialty involvement. But at this time around, we figured out that at least this experience, since the borders have opened and with this current influx of patients, it seems to be very much a single organ respiratory failure predominantly. But having said that, these are still early days and we need to see how this all pans out. But it seems to be the current variant has got a different flavor to it as compared to the previous ones. In a way, I think it's actually beneficial, mainly because we get to understand the disease better. And also, from the patient's point of view, it appears that they're not as sick as the ones which presented with the Delta variant.
Do you keep counting ED? Of how many people that you can see?
We're seeing about 80 to 100 people a day who have COVID. And that's given confirmed COVID. And of that, we're admitting about 40%. And just in terms of, so in the last 10 days, the 102 ward team has discharged 201 people. So the workload has been absolutely phenomenal. And the average length of stay for each of those patients was 4.5 days. And really what we're seeing is there's a group of people who are very unwell and then go on to sometimes require care from our ICU colleagues, and largely they're younger unvaccinated patients, which is unfortunately still a significant issue in our community. And we do have, several family groups who have chosen not to be vaccinated, where we've got multiple family members who are admitted. So I really would put a plea out, if anybody still thinks that not being vaccinated is okay, please just reconsider, please get vaccinated, because we really like you, but we don't want to see you. So, it is irrefutably true that vaccination is going to reduce your chances of needing to be in hospital and definitely reduce your chances of needing to see these lovely people. The other group that we're seeing is often frail older patients who, particularly from home, who may have other comorbidities, who, they get a viral illness and it happens to be COVID, and there's a lot of COVID in the community, and it's enough to have them have challenges with their breathing or have a delirium or have difficulties with some of the GI symptoms as well, and just generally just profoundly lethargic and really, really challenged in terms of maintaining their own self-care. And then there's another group that we're seeing, which is people who maybe from supported disability facilities or sometimes from residential aged care, who have COVID, but also just aren't able to have their care needs met in the community. And I know Leslie's been involved in doing a huge amount of work to maintain as many of these patients, particularly in residential aged care. And I think it's really important to acknowledge the amazing work that the RA geriatrics team has done to support a lot of that. So Chloe First, Ashita Barter, and and Mark and Helen, who are the nursing leadership, have just done some amazing things in the community in recent weeks. So really from a 102 perspective, we are seeing people who do have quite significant illness, but we absolutely acknowledge that the vast majority of people are managing this illness in the community, like we would with any other viral illness.
So is there been a patient story that's stuck with you so far from an ED perspective that's come through?
Yeah, it's a difficult question because we see so many people, so there's more of a broad perspective on this. So I guess the variety of people that we're seeing, it really highlights just that COVID doesn't discriminate. It doesn't matter your age or your health status, you are at risk, and just echoing what Megan was saying, that, we need to all do our best to stop the spread and consider vaccination if you haven't already been vaccinated. It's really important because we're just seeing so many different people.
I guess the same question for you and us.
Yeah, look, there's a couple of probably patients that I know Chris and I had spoken about, and it's more so not the actual individual patient, it's that it can affect a whole family. And we've had a couple of husband and wife teams in ICU, and also a son, auntie, mum, dad on the wards, two of which have ended up in ICU. So it's not just affecting one person in the family, and then that knock-on effect can really devastate a family, potentially lose a whole family. So from our perspective, that real vulnerability of a whole family can be quite devastating. So our ability to communicate and connect with those families is just so important right in their time of need. Yeah.
So this has been a really exceptionally difficult couple of weeks for everybody in your teams. How have you guys been actually looking after yourselves and each other and your colleagues' well-being through this time?
So I think it's been unprecedented in a way, mainly because we knew this was going to come, but it's come a bit too sooner, and it's been a bit precipitous as well. But more importantly, I think the learnings from the previous waves, as we spoke about, I think we had the structure and more importantly, the resilience to face that. So the adaptability of the staff, I'm speaking on behalf of the intensive care unit, but more importantly, the critical care and very program has been really top notch. I'm really proud of the way people have adapted to it and have stepped up, as I said earlier, and more importantly, the compassion shown to colleagues and actually people, cancelling their leave and coming and working on their own, again, curtailing their leave, and even people. I can give you an example of my colleagues who are currently supposed to be on leave, but here are doing the work, attending meetings and making sure that we have the troops on the ground. So all of that essentially, comes to the moral compass of my colleagues, and I think that's where this is all about. And also, we have systems within the unit, and because it's a high-stress environment, so we have a mentorship program. We make sure that the trainees are looked after well, getting their regular breaks, and also having someone to speak to. The experience from the eastern states has been that the peer support model has always worked well, wherein people really need to decongest their feelings and essentially have someone to talk to. And we don't want anyone to suffer in silence. So we encourage people to talk, obviously mindful of the social distancing issues and also the limits in the rooms. But also we encourage them to at least, have a conversation every day on how they feel, because we believe that helps people to actually vent and at the same time reflect on what happened. There's been a psychology support service, which has been really helpful, and Andre would concur with me that we are trying to promote that in the days to come. We had good benefit from that during the previous waves, and we'll continue to do so.
And from an ED team perspective?
Yeah, I mean, very similar story to ICU. Extremely proud of the team in ED. People coming back from leave, people not taking leave, people doing double shifts, everything to help out the team. I think it's just been amazing just to see how quickly we all come together in time of crisis. Some of the initiatives that have started in ED, we have 3 breakout rooms. So they're rooms that stocked with food and water. That's part of the wellbeing committee has helped with that, and that helps people go in there. They can take off their PPE, they can have a quick hydration, a break, you know, from the work and being in all this PPE, and then obviously come back out on the floor. Just trying to increase the amount of breaks, you know, people are having to give them a rest from PPE is really important. And we've got the psychologist that's just started as well, doing small group sessions, but also available for one-on-one, just to talk about anything. You know, we don't want anyone to suffer in silence, and it's really important to talk, you know, talk through anything. You know, it can be a really stressful period of time. And as a leadership group, the nuns, there's several of us that we've extended our hours, and we're working over a 7-day period as well, just to offer that senior nursing leadership as well.
It's been really incredible to watch, for me, a little bit at a distance. And there was a lovely social media post last week, which I see you haven't talked about, where there was a delivery of pizzas, I think, to ED with this most amazing note on it. I'll make sure I put it in the Friday email today so that you get to see it, which was literally thanking the ED colleagues for the work that they did. You've heard the volumes that, you know, sort of the ED and the 102 pathway are dealing with. And as Chris said, we never expected to get to this number so quickly. And so that's meant that in some ways we're continuing to adjust our plans in the moment. And the other thing that my colleagues haven't talked about, but I do want to acknowledge, is that they are often dealing with that end of life, you know, issue with somebody with COVID. And I know, Andre, you talked about caring for the family, but in fact, it has made it really difficult to be able to provide that level of care. And I remember last time, Chris, it was something that we really needed to support the staff, because, you know, this is not about being able to always just bring somebody in, but we are going to revisit some of our visitor protocols, because we really do need to make sure that our care is that comprehensive care and really wrapped around and in the best interests of that person. The numbers have just made that a little bit more challenging, as what we've tried to do is make this a really safe environment.
So I probably will just finish with one last question. What is it that you want people of South Australia to currently know about what you guys are dealing with every day? And is there something, a message you'd like them to know generally about what we're looking at currently?
So I think it's really important, and I guess one of the aspects I really reflect on is that we're humans looking after other humans, and we just can't lose sight of that we're doctors, nurses, allied health professionals, and we're caring. And one of the medical lead colleagues, Marcia Fogarty, had a brilliant observation in a meeting last night. She said, you know, this is a once in multi-generational opportunity to serve. And I know for many of us, we take that responsibility incredibly seriously, that we are here to serve, and we're here to serve our community, and we're here to serve our patients. And, you know, I think all of us, it might be hard to see because we all feel like we're up to about here now, but we'll reflect on this as an amazing opportunity to really give to our community and do what we're trying to do. And for me, it's really seeing everybody step up, and everybody step up in new and unusual ways that they never ever thought they would. You know, we have a physio working as a COVID navigator, Ellie, she's superb. And it's everybody just thinking, how can I do this and how can I help? And, you know, our cleaning staff and the emergency department are absolutely brilliant. Partnering with Spotless has just been fantastic in terms of them saying, what do you need? How can we support you? How can we get you what you need to do, what you need to do? In all of this, though, I think we just need to really get across to people that we've had 2 years of being told that COVID's really scary, but it's a virus and it's a human. And we really just need to remember how therapeutic touch is, appropriately PPE, of course, but, you know, it's that humanity and the actual touch and doing the doctoring and the nursing that is so key to how we deliver care, whether the patient's got COVID or not, or doesn't have COVID. And we need to just never lose sight of the fact that it's a human and they happen to be our patient and they're here for us, here to have care from us.
Yeah. I would like to agree with the importance of vaccination. And so certainly we have lost 4 patients, unfortunately, in this current episode. And the vaccination status, 3 of them at least were unvaccinated. And so it's a very clear message that, unvaccinated patients tend to have adverse outcomes. So the message out there for the community would be that from an ICU point of view, please come to the vaccination and get yourself immunized. And that actually is a step in the right direction, and that helps not just the individual, but the community, the family, and that is the way to go. And also to highlight what Megan just said, I think this is a once in a lifetime opportunity for us to serve the community. And, we are prepared for it, for this wave and the other waves that are may come, but having said that, we're just here to do the job and we've got your back.